after 3 days. So we were taking somewhere around 20-25 impressions every day, and it was not getting approved. So it was tough time. We used to be bashed daily, but it was so. Then Ajay Singh sir joined, and we were told that one of a very senior faculty from KGMC will be joining the college. So, and we were told that he is the ex-dean, and he is a legend. So fortunately, SK Singh sir came, we met him, and the first thing Dr. SK Singh sir told us, go and get a topic for your thesis. So it was something like I was waiting for. At that time, I still remember there never used to be these smartphones. The internet connection, broadbands were not there. And I still remember there was one computer shop in front of the college. We used to go there, collect 5 to 10 articles. And I wanted to do a research or my thesis on implants. Because for me, implantology was the biggest thing. So I thought I'll do the best thesis and I'll go for a Nobel Prize. I will try to get a Nobel Prize in this topic. So I gave 5 topics to SK Singh sir. He said, "Acha, chalo, come next week." Then sir, next week said, "आपने topic नहीं दिए?" I said, "Sir, दिए थे." नहीं, वो और लेके आओ. Again, so after 15-20 days, na, I had given already 35 topics, and sir said, "मेरे room में आओ." So I went to sir's room, and sir told me, "आप यहाँ क्या करने आए हैं?" I said, "Sir, Prostho. In post graduation, I want to learn Prostho because in graduation I didn't knew anything about Prostho." He said, "आपको कौन सिखाएगा?" I said, "Sir, आप सिखाएंगे." So he said, "So I am gonna be your guide." मैंने कहा, "Yes, sir, definitely." So if you want me to guide, then I can only guide you for a topic which I know. ऐसा topic select करो जिससे मुझे आता हो. I don't know anything about implantology. So those words are still in my ears. Just imagine a person with the caliber and with the repo of Dr. S.K. Singh sir telling me that he does not know this thing. You must have seen so many people, they are boosting daily, day and night. They know this, they know this, there's no. But you never see a person who is telling you openly, a first graduate, postgraduate. Just imagine a person with the caliber of Dr. S.K. Singh telling a first year postgraduate, "I don't know this thing." That tells the honesty of that person. That tells how that person is grounded, how pure that soul was, how much dedicated that person was for Prostho, because he wanted, I should teach what I know. That was hardcore, pureness I could actually see in Lucknow. And same thing during 3 years, I felt similar thing in Dr. Ajay Singh sir. I was blessed to be groomed by these two pioneers in prosthodontics, Dr. Ajay Singh sir and Dr. S.K. Singh sir. I sometimes still miss Dr. S.K. Singh sir because even after my post graduation, whenever I was in a problem, I used to call Dr. S.K. Singh sir. I thank you very much. First of all, I really want to wish you all a very, very happy Prosthodontist Day. I think it's a wonderful initiative by the Indian Prosthodontic Society. It's not being celebrated in India, it's being celebrated all over the Asian countries in association with the Academy of Prosthodontics. And as a treasurer of Indian Prosthodontic Society Chandigarh branch, I wish you all a very, very happy Prosthodontics. Now, there's a very good line that is written on this. The God creates and we recreates. This word has a very, very deep meaning. We are the one who need to recreate. Now, there are many dilemmas in life. When you are in 10th, the biggest dilemma is which branch you need to select. Whether you need to go for humanitarians, a commerce branch, a medical, non-medicals. Then you come into BDS. There are a lot of dilemmas during BDS. Then after post graduation, some people have the dilemma which branch to select. For me, after post graduation, the biggest dilemma was whether to join academics or be a clinician or a private practitioner. So there are so many dilemmas in our daily life. So the dilemma which I'm going to talk today is, what are we? Are we prosthodontists or we are becoming implantologists? And this dilemma is for everyone. Either you are a postgraduate student, you are an academician, or you are a clinician. This is a biggest dilemma. Who is an implantologist? If you ask me, an implantologist is a person who rehabilitates patients with an artificial structure that is put inside the jaw bones called as a dental implant. Prosthodontist. Prosthodontist is basically a person who knows the art and science which is pertaining to the restoration, the maintenance of oral functions, the comfort of the patient, the health of the patient, the appearance, the complete stomatognathing system, which is associated with any lost natural tooth structure or any associated structure with either a removable or a fixed substituent. It can be anything, but it has to rehabilitate according to the oral functions, the comfort, the appearance, considering the entire science of the stomatognathing system in mind. I tried to find a picture I can place here. The most suitable I could find was this. This picture was taken the day I finished my grand viva in the third years. We all look very young. I was blessed to have these people around me. They are still like my family. This is Dr. Shitij, Dr. Mandeep, my batchmate, Dr. Ajay Bansal. They were actually the strength for me. Then you have Dr. Gaurav Singh, Dr. Rahul, you have Dr. Abhinav, Dr. Javaz, Dr. Imran, what a fabulous personality he was. Dr. Preet, Dr. Rohit, they all are wonderful people. I was blessed to be in company of these people. Now let me share with you a data. I said, if I asked Dr. Shitij what type of topic he wants, he said, one of my best topic where I take a lot of lectures is in occlusion. But Dr. Shitij told me, sir, you need to have something different because PGs know a lot of what academic stuff. I said it. So we decided on this topic. So I asked whether this topic is relevant. So I tried to figure out a data. I was very fortunate to get this data from one of the very popular labs in Delhi, in the NCR. You see, the number of cases they were doing in 2008. So they were doing somewhere around 210 cases per month for tooth supported fixed partial dentures, and somewhere around, you can say, 120 cases for implant supported restorations. Just try to see the change in your demographics. As we are progressing, the number of cases for tooth supported fixed partial dentures are reducing. And somehow, the number of cases for implant retained restoration, whether they are single implant supported crowns or there are multiple units on implant supported restorations. Now just see this trend. So this trend generally depicts something. It means, is the science of implantology gaining more importance than tooth supported? It means scientifically there's something that needs to actually approve this. So I just tried to figure out, is this trend absolutely fine? Are we going in right direction? One of another lab in Mohali. After NCR, it's one of the largest labs in North India. You see the number of cases they are doing here in 2000, 2007, 2015, 2019. So it means If you see the trend, the implant supported restorations are actually overpowering the tooth supported fixed partial denture, which generally gives an indication that this treatment might be more successful or it is the only successful treatment in the patients. So we need to find out, because for a postgraduate student, it is very, very important to know the facts, because 3 years is not a big time. You are supposed to learn removable denture processes, and I think first 1.5 years is complete dentures and removable partial dentures. Then you are supposed to do your cast partials. You're supposed to do the FPD, tooth supported FPD. You are even supposed to do maxillofacial cases. You're even supposed to know a lot about occlusion, which is in itself is a big study. It's a science. You need to understand the temporomandibular joint, and now implantology. Now, implantology is not just a mere section, because if you are learning implantology, if you're learning direct sinus lift, if you're learning ridge splits, if you're going for advanced surgeries, absolutely fine. But should this basic conventional prosthodontics should suffer? I don't think so. And this is actually, unfortunately, the trend. You ask a first year, you ask a third year graduate what he wants to become. He wants to become an implantologist. I told you last week, I asked my postgraduate student to get some thesis, and all the topics were implant supported. They wanted everything should be related to implants. So it means dental implants has actually overpowered the dentistry, the conventional dentistry. It has revolutionized everything. It has revolutionized to such an extent that DCI, the governing authority, was forced to change the name of the branches. Periodontology was changed to periodontology and implantology. Prosthodontics, crown and bridge was changed to prosthodontics, crown and bridge, and implantology. And I think in oral surgery also, now implantology has been done. It means that this branch of dentistry has such a great influence on the entire science of dentistry. But why it is happening? Why is dentistry moving towards dental implantology? Obviously, there's a huge progress, development of new implants. Every month there's a new company. Every month there's a new advancement. There's a new diagnostic procedures, and there's so many novel surgical techniques that have been incorporated in recent times. CAD/CAM has made a huge impact in the predictability of implant restorations. Access to education. Now, access to education is very easy. I was 2018. I was the president of an IDA Mohali branch. We conducted somewhere around 12 courses in 1 year, and you will not believe it. Out of 12 courses, 10 were related to dental implantology, because everybody wanted to hear implantology. So there's you pick up your social media, and every day you get a new course. There's so many private institutes, there's so many universities, so many professional societies who want to bombard you with implant courses, and they actually award you a degree for implantology. Profitable, the big factor. I see the successful implantologists all own a BMWs, a Audis, a Mercs. You'll not believe, I went to a conference in Bombay. That was an implant conference, and the Audi people sponsored that conference. Now, these multinational companies has a huge HR department behind them, and if they are sponsoring, they find that the people who are doing implantology are their potential customers. So profitable is a big aspect that is actually forcing us toward going towards dental implantology. Obviously, preservation is the key, and this is one of the factors. The first thing we tell a patient to go for implants is we don't want to unnecessarily sacrifice your adjacent teeth. So preservation, now this is a relevant point. If you see the basics of any prosthodontic treatment, the first point is the famous Bevan's concept of preservation. You need to preserve what is left. Then you need to plan for the replacement. Is a big factor, no doubt about that. You are getting more retentive processes when it is implant supported. But you have a darker side also. You cannot ignore the darker side. And you start seeing this darker side after 6 to 7 years of doing implantology. You start seeing patients coming back. Who is a successful implantologist? You ask the company, people come, you said, that doctor is doing 200 implants a year. So he's a very successful implantologist. You should also do that. But from a scientific point of view, a successful implantologist who is able to achieve a good osseointegration. Now this 10 years back, this was still a debatable topic, but now this osseointegration is a proven fact. Out of 100 cases, if you have done 99 cases, you will get osseointegration. Now we have moved ahead of osseointegration. After 3 months, the implant should be immobile. There should be no persistent pain, no infection, no paresthesia. Generally, next day we ask the patient after being numbness, numbness is back. So this is the criteria of being awarded a degree of a successful implantologist. What about this? Now this is a 3-unit implant retained prosthesis. It is osseointegrated. There's no pain. There's no permanent discharge, no paresthesia. But will we call this as a successful treatment? For me, if a prosthodontist does this, he could have achieved a better aesthetics with a simple removable denture, a basic first-year postgraduate. Now this is a 2-unit RPD, a beautiful color matching acrylic, 1 unit, 2 units here. That is also here. What about these cases? You see, these are implant retained restorations. This is a full implant rehabilitated. I don't know where's the occlusion, where's the aesthetics, what we call as the guidances, but do they we consider them to be a part of a successful implant restoration? How down? Now, who is a successful prosthodontist? The first thing about a successful prosthodontist, he understands patients' needs and wishes. He understands patients' chief complaint. He understands, are the needs and wishes genuine? He restores the missing teeth prosthodontically. It means he knows that this is a restorative science, which is restoratively driven, not surgically driven. He offers different remedies for replacement of missing teeth. It can be a removable denture processes. It can be an FPD, and is aware of a complications. A person who is not aware of complications is going to have a big back in his practice, even in academics. You should know what complication you can face, whether you can tackle that or not. Then your treatment planning should start. The treatment should always be scientifically or evidence-based. Does the research, does the data shows that this trend is good? We'll try to find out. Out of these procedures, the first procedure for a prosthodontist is always a complete denture. This is the core of prosthodontics. You can never sign out these procedures. First 1.5 years, we only made We were told to make these things, and we were only made to actually inculcate these basic principles of complete denture. So this basic treatment, you cannot sign it off. Then you have the removal partial dentures. So I'm not telling you what are the indications, what are the indications, because if I tell you 5 indications for complete dentures, 5 indications for removal partial denture, one of a postgraduate student might say, so there are 6. Because academically, any day, you people are on top of everything. A removal partial denture, a simple case, a patient comes, the chief complaint, I need a restoration, which should be fixed and I should be able to move. I should be able to chew with it. Hygiene is a big factor that you should always consider when doing a treatment planning. So retain 2 centrals, 1 retained canines, post and core. Now this is a removal, a gum fitting removable partial dentures, a cast partial denture framework. It's 2 circumferential casts on the molars and attachments. And this is almost a fixed restoration. But the biggest advantage in this case is the patient can remove and clean. If the patient is not able to clean any processes, how much hanky-panky processes you give, it is bound to fail. The hygiene is of paramount importance. Then you have fixed denture processes. You can have tooth supported, you can have cantilevers, you can have resin bonded, you can have implant supported crowns or implant supported FPDs. You all are well aware of what are the indications, what are the contraindications. I am not going into those details. Now, I'll just discuss with you a few clinical cases that will actually be very relevant, and you can yourself tell whether this case was prosthodontically driven or it was implantology driven. And what is the difference? You'll come to know when you see the cases. The first case, a patient comes, this was an OPG, the chief complaint was, I cannot chew. Most of the times the patient comes for a replacement of teeth. They don't come for implants. The chief complaint is, I want to chew. We gave the patient different options. He said, I want a fixed restorations. I don't want to remove it. I said, okay, we'll be giving you fixed restoration, but you have to maintain oral hygiene. You need to use a regular dental flosses. You need to use water picks. And every 1.5 years, you need to come back for your oral hygiene regime. What does that oral hygiene need to use? We need to actually take out the processes, clean it, polish it, do the prophylaxis, and change the screws. Because every time, I'll show you the screws. So these were the 6 implants that were placed in the maxilla. 4 implants because there was no bone in the posteriors. 4 implants in the mandible. These were the restorations. These are the titanium milled acrylic processes. These are the small screws that are retained over the multi-unit, and every time the patient comes after 1.5 years, we change these screws because every time you torque it, there's always some amount of strain. Now, again, you torque it, there's always a tendency you might fracture. So after every 1.5 year, 2 years, patient come back, we remove the processes, clean it, do the polishing, and again fit it with new screws. This is told to patient prior to starting the treatment. So it means this treatment has a maxillary and mandibular implant supported fixed restorations. The chief complaint, I want to chew. I want fixed teeth. So the patient's needs and desire were met. This was the X-ray after 1.5 years. 6 implants here, 4 implants here, and this is after this. I got this done, I think 2 days back only. I told the patient to send me the next way. This is after at least 2 years of rehabilitation. Case number 2. A patient comes again with the chief complaint, I want to chew. I'm not able to chew. What will be the choice of restoration you can give me? I said, get a CBCT done. Only then we can plan this. We got the CBCT done. You see the amount of bone in the maxilla. It was not sufficient to placing implants. Mandibular, it was fine. So the patient was given an option. Either you can have both maxillary and mandibular removable dentures, or you can have a maxillary removable dentures and a mandibular implant supported removable dentures. The patient was given an option of getting a direct sinus lift or bone augmentation. Generally, these type of defects should be done with a bone augmentation procedure that is bilateral. That is the Curie's technique. You take a bone plate, augment it. The GBR procedures, somehow I'm not very comfortable with those procedures. So the patient opted, I need a fixed restoration, but I don't want to go for those aggressive surgical procedures. So we placed 5 implants in the mandible. This is at the time of after 3 months of placing the implants. These are 5 implants, 5 multi-unit abutments, open to impression, the jig trials. Now this is one of the things I actually do in all my cases. I still remember Ajay Singh sir taking a pencil and doing it in every case. A maxillary removable denture processes and a fixed removal processes. So it means a maxillary removable and a mandibular implant supported restoration. I have been seeing this patient from the last 2 years and there's no problem. Definitely I have replaced, I have changed, I have taken it out, cleaned it once, and patient is not having any problem with maxillary, with the retention of the maxillary. Because we as a prosthodontist know that we can give a good maxillary processes and a mandibular removal processes. That is our strength. We have this confidence that we can give a good retention in the maxilla and in mandibular processes. This is the patient's smile. A third case. Again, the patient comes. You have caries all around. You have missing teeth. The patient comes for the restoration and a replacement of missing teeth. You can see a collapsed bite. There's hardly any space here. This is the maxillary intraoral picture. Now just see this. All these teeth extracted and 4 implants placed. After healing, a very good looking processes for maxilla. Implant supported fixed restorations. Mandible. Patient only has 1 teeth that does not look good. All the teeth were extracted, implants were placed, and a good restoration was given. So from here, the patient was moved to here. Now, it looks wonderful. Picture-wise, it is wow, what a treatment. But you just need to think that the prosthodontic code, God creates, we recreates. It is not we replace. We should recreate what is left behind. We are the one who are supposed to replace the missing teeth. We are not the ones who are supposed to extract the remaining teeth. The preservation is the key, the healthy teeth. So I don't find this treatment to be prosthodontically driven. This is surgically driven. Another case, a patient comes back with this type of condition. A hopelessly teeth here, a collapsed bite, a severely worn out dentition. The patient was using a removable dentures, but the patient was not able to chew. He said, I am not happy and you please extract and give me a complete dentures. So I told the patient, you can go for implants and all those treatments. He said, no implants. Because he had so much dental treatment throughout his life that he feels that dental treatment cannot make a difference. Now, fortunately, his son was a dentist. So I told him that let us try to recreate your lost dentition. So what we did was, this was the intraoral pictures. You see again a collapsed bite. There's hardly any interoral space here. Similarly, upper. Now this If you see this, this is a very easy case for just extracting these, doing some kind of osteotomy, placing the implants. But we actually tried giving this patient a prosthodontic approach. We did a Facebook transfer, took a centric relation, and did a wax up. And we just transferred that wax up in the patient's mouth. You see, we just made a putty index and we transferred it with a protein solution and we transferred it in the patient's mouth. And we asked the patient to look at it. Just see the amount of difference. So we have been able to restore the patient to its actual vertical. The plane of occlusion is maintained. And on the very same day, the patient's existing removable dentures, we added autopolymerizing resin because I cannot send the patient without this. Now he will break this. And we send the patients. The patient came back after 15 days. He was perfectly fine. Then the treatment planning was discussed. Now these are the final restorations. Just remember this lateral incisor, it was just a small root, a small structure. All these teeth have been retained. The teeth has a very good proprioception. How can we afford to extract the teeth and lose that proprioception? The removal processes were given, a simple removal acrylic processes were given in the posteriors. Just imagine from here to here. Now it might does not look as good as the implant supported fixed partial dentures, but just remember that this is what is the main aim of a prosthodontist, to recreate rather than extracting a teeth. Now, I saw this patient last year only. He lives in Canada. He came back. Now he says, can we do something in the posteriors? I need something fixed. Just see. Sometimes you need to do a treatment to gain the patient's confidence. A small filling, anything small. Now the patient who actually jumped out of the chair when I told him on the first appointment we can give implants, now he says, can we do something in the posteriors? I said, yes, you can get a CT scan, then we can plan for implants in the posteriors. He said, due to pandemic, I need to go back. Next year, I'll be coming. And I think that this patient will again be able to go for implant supported restoration in the posterior teeth. Now, this is prosthodontically driven. Case number 5. Again, a similar case. A worn out dentition. The patient's chief complaint, I want to chew. Unfortunately, all the teeth were extracted. A maxillary fixed implant supported restoration, a mandibular fixed implant supported restorations from here to here. I told you from pictures it looked wonderful. But the problem with these type of cases is how can we assure the patient that this will last for a lifetime? Do we have that confidence that these restorations will last for a lifetime? I don't think so. The implants have more technical complications. And the complications for implants are difficult to handle as compared to the complications of tooth-supported restorations. So I always said a known devil is better than an unknown devil. Let's see a case number 6. Again, the chief complaint, I cannot chew. You see, you don't have bone in the posteriors. You have good amount. These are small, tiny, many teeth. The CT scan shows there's no bone in the posteriors. We did a different approach in this patient. So if the patient would have insisted, now the thing about this patient was, it was easy, very easy to extract these teeth and place in implants. Now this patient comes from a place which is somewhere around 200 kilometers from where I practice. This patient comes on a wheelchair. So it means I need to give a restoration which has a smaller or a lower complication rate. So what we decided, we took a Facebook transfer, again recording a centric relation, did a wax up, made a putty index, and the max this is the putty impression. We transferred in the patient's mouth, and we gave a restoration, a zirconia supported restoration for the maxilla. Because this was a long bridge, we had to give a broad connectors. Now mandibular, we give a cast partial dentures. You see cast partial dentures with precision attachments. Now I've been seeing this patient from last 5 to 6 years, and she's doing perfectly fine. So just try and imagine what kind of treatment would you like to give to your mother, to your elder sister. Would you love to extract the teeth, or you will try to save the teeth? So whenever you are treating a patient, treat them as if you are treating your relatives, your mother, your father. If I would have given a implant supported fixed restoration which has technical problems, if something goes wrong, how would the patient come from 200 kilometers on a wheelchair? It's not possible. Now these treatments are the tried and tested treatments, and we know that if proper given cast partial denture, that is one of the most wonderful things. Number 7, a young girl, hardly 18 years, comes to a clinic. She had a trauma one month back. So this was buccally displaced. This broke. This also broke. This also broke. We did a vitality test. These two were non-vital. So what we did, we just did a wax up, and we transferred the wax up in the patient's mouth with the protemp. You can still see some amount of protemp flowing in. We got the CT scan done. Now this teeth was buccally pushed due to the trauma, and there was no buccal plate here. So we gave an option of doing a GPR first after 6 months restoring within implants. But these teeth were again non-vital. So it means anyway we need to do a root canal for these teeth and give a crowns. So the patient opted for a non-surgical approach. So we did tooth preparations from here. So we give a zirconia bridge from here, central, lateral, canine, and the premolars. Obviously, the premolar was post and code. From here, we give an immediate provisional after doing preparations. This picture, I could not find the actual picture. This picture is with the provisionals, or these are protems. Now, this is patient's smile after getting the zirconia crowns. So the chief complaint is aesthetics. It is not I need implants. I need replacement of missing teeth with good looking teeth. So this is prosthodontically driven. So all these cases, you can very well imagine which of the cases are prosthodontically driven and which of the cases are implantology driven. Ethics is not knowing the difference, what you have the right to do, but it is what is right to do. You go to Instagram, you see your Facebook, daily you see a lot of cases on all on 4. But you hardly see any cases on fixed partial dentures. I was very fortunate to meet Paulo Malo. He was here. I said, your technique is very fine. What about the complication rates? He says, I am doing treatment all on 4 in those cases where implants are not possible. It means, although it has complication rate, but still the patient is getting a fixed restorations, and the patients are told about the complication. What he means to say is, this all in 4 treatment is for compromised cases. It is not every case is a case for all in 4. If you can place 6 implants, if you can place 7 implants, it is better. Where is a compromised bone, the patient does not want to go for advanced bone augmentation procedures. It does not make sense you have the right to place implants in every case you are placing implants. The patient is not has not come for some kind of a treatment for a deficiency. Patient does not have the titanium deficiency syndrome. Why are we unnecessarily converting every case to an implant supported restorations? So implantologist only knows one method of replacing a missing teeth, that is implants. Whether right or wrong, he does not know. But every case is implant, keeping in implants in mind. Whereas a prosthodontist has all the different treatment options available in his kitty. He can give a removable denture prosthesis, he can give a tooth supported, an implant supported, a cantilever, a resin retained prosthesis, and he knows what are the proper indications, contraindications, and complications of these treatments. So, what does the scientific data says? Everything is not just seeing the pictures and not seeing the data. If you're seeing a lot of cases on Instagram, if you see a lot of techniques, new techniques on Facebook, you should first evaluate the scientific evidence behind it. So I have tried to compile some of the scientific evidence. What does the evidence say? Are we moving in the right direction? The first slide I show you. Now we are doing 10 times more implant cases what we were doing 10 years back. And only 10% of the cases in terms of tooth supported restorations. So whatever scientific data I was able to collect, I categorized into two things: the survival rate and the complication rate. Now, what does this mean? The survival rate means that how long that process is surviving. 5 years, 10 years. It has nothing to do with the complication rate. Survival rate means it is there in the mouth. Whether the ceramic is there or it has chipped away, whether there's some problem, it can be biological, it can be a technical problem, does not matter. It is in the patient's mouth after 10 years, it is the survival rate. And then what is the complication rate of each processes? I was able to find that implant supported FDPs and single crowns have a complication rate of 33.6% after 5 years. Now, this is a big complication rate. It means every out of 100 cases which you are placing, 33 cases will come back with complications after 5 years. What about implant supported? What are the complications? The technical complications are fracture of veneering material, loss of access hole restorations, abutment or a screw loosening, loss of retention. Now just imagine, we generally say veneering of fracture is not a big complication. If you're given an implant on the front teeth and the ceramic chips off and it is a cement retained restoration. Now you can well imagine how difficult it is to cut a porcelain fuse tooth or a zirconia crowns and then again take an impression again. This is a big technical complication. The biological complications, periimplantitis, soft tissue complications. Now, periimplantitis in itself is a big size today. A lot of research is being done in terms of periimplantitis. Recessions, you need to have the ability to do connective tissue grafting. You need to have the ability to do free gingival grafts. You should be knowing that these treatment might require the advanced surgical procedures. For the conventional FDPs, you also have complications. No treatment in this world is free of complications. I tell my patients, whatever I am doing in your mouth, I'm trying to repair that thing. And every repair has a complication rate. The only way I can reduce this complication is by maintenance. And you are the one who are supposed to maintain it. If you don't maintain it, any treatment will fail. years, it is just 15.7%. Even after 10 years, it is only 29%. For implant retained, it was 33.6 after 5 years. So what are the complications of FDPs? You have the technical complications, fracture, veneering material. It is here also the framework fracture, loss of retentions. You have the biological fracture complications, loss of vitality, caries, abutment. But I, as a clinician, sometimes feel that these complications are still manageable. I'm not saying that implant complications are not manageable. Now, just imagine you have given a tooth-supported fixed restoration, and the patient comes back to you after 10 years that now this has broken. Now he will not complain that much to an extent. Whereas implant, even if it fails after 12 years, the patient will hold you from the collar because you are the one who convinced the patient to go for implant supported restoration, which you claimed will be for lifetime. There is nothing as lifetime. You go to orthopedic surgeons, the people who are doing knee replacements, they do a knee replacement and tell the patient you might require a reconstructive or the new surgery after 2 years, after 3 years. Do we tell the patient that you might require a soft tissue augmentation surgery after 2 years if this? You might require a GBR procedure if this complication. We never tell the patients. This is a problem. We need to tell the patient and make the patient aware of the complication and then decide on the treatment planning. This one of the very good articles I was able to find. It's on clinical oral implant research. It is by Jettison. He actually did a very huge study. He compiled somewhere around 85 different studies to see the survival and complication rates of FDPs and implant supportive crowns. Now, each of these studies, out of these 85 studies, each of these studies has a data of 200 cases. So you can well imagine how huge this study was. So he came to a conclusion that tooth-supported restorations after 5 years, have a survival rate of 93.8%. The cantilevers, if given where it is indicated, has a survival rate of 91.4%. A resin bonded, a Maryland, and any of those restorations have a survival rate of 87 point. Now we can justify because debonding is a very common phenomena. Definitely things have changed with the advent of adhesive dentistry and with the advent of lithium disilicate, which has a very good bonding. Now, implant supported fixed denture processes have a survival rate of almost 95%. This is 94, this is 95 after 5 years. These are implant supported bridges. Now, single tooth implant supported FPDs have a survival rate of again somewhere around 95%, 94.5, and a tooth to an implant supported. It means one of the abutment is a tooth, the other abutment is an implant. It also has a survival rate of somewhere 95%. It looks that this is also a viable option. Now let's see what was the survival rate after 10 years. This was reduced to 89.2. 80.3, a huge reduction after 10 years. Resin bonded 65%. Implant supported restorations 86% survived after 10 years. Now just compare it with tooth supported, it is still 89%. Single crowns, again it is 89%. Now just see this. It is hardly 77%. It means that the option which looked very viable after 10 years, it is not a good option. So seeing this data, what was can be the choice of treatment? It can be a tooth supported restoration, it can be implant supported, or it can be a single tooth. Now these are the first line of treatment for a prosthodontist. Then obviously cantilevers, resin bonded, or if the things are favorable, you can even plan for tooth to implant supported restorations. I have given this, and in those cases where the patient's mandibular teeth, suppose it's the first premolar, I placed implant on the first molar and given 3-unit bridges, but the upper maxilla was a removable dentures. So you as a prosthodontist know what amount of biomechanics you will be facing. If according to you the biomechanics is favorable, this can also be. But resin retained cantilevers, this is always not a very good option. I am giving cantilevers, I'm giving resin bonded, but mostly these are interim restoration for the time the implants are healing. Now, there's again a very good study by the Department of Periodontology and Fixed Prosthodontics at University of Bern, Switzerland. Now, this university is doing a lot of work on implantology. In fact, most of the pioneers of the ITA team are from this university only. So they actually came out with the data of mean survival rate after 10 years in function. The conventional FPDs, it lasted for almost 96% of the cases, even after 10 years they were there. Cantilever FDPs, where it is indicated, they lasted for 84% cases. Implant supported for 94%. Implant supported FDPs, implant tooth supported was 70%, and single implant supported was 89%. So it means if you see the data, if you see, then conventional FPDs, the conventional tooth supported, which is the hardcore essence of prosto, still has the maximum amount of survival rate. I'll not say that implant supported has a lesser survival rate, but I can say that they have equal survival rate. So this data was from 2007. Now we are in 2020. So I tried to find out that after 2007, there's a lot of increase in science, there's a lot of innovation. Now has the things improved over time? So I could find another article which actually compares the articles before 2000 and the articles after 2000. You see, now this is before the articles before 2000. It says that implant has a survival rate of 98%. After 2000, the article says it has a similar survival rate. So there was not much of difference. The prosthetic survival rate before 2000, all the articles mentioned somewhere around 93.5%. After 2000, now this survival rate has increased. This is prosthetic. Now this is due to digital dentistry. You have more passive fitting prosthesis. You know, you cannot compare a castable prosthesis with a titanium or a chrome cobalt milled prosthesis. This passivity has a major role to play in survival rates. The implant restoration should always be passive. Complication rates. Before 2020, all the papers said around 14% cases had complication. Now just see after 2000, it is 27.8. It has increased. More number of complications are being reported. Now either it can be two reasons for this. Either more reporting is done, and it is directly proportional to the number of implants we are placing. The huge number of implants we are placing, the more the complications. Now let's see, what about the complications? The aesthetic complications have reduced. The biological complications have reduced. This is for single crown, this is for FDPs. The biological complications for FDPs have increased after 2000. Abutment screw loosening has increased. Abutment screw fracture has increased. Now, loosening and fracture is directly related to interferences. As a prosthodontist, you know how to remove the interferences. You know the science behind occlusion. Veneering of fractures, it has increased tremendously. It means we are placing the implants without actually checking on the occlusion of the patients, and that is without having proper knowledge of occlusion. So the key points, if you check about the complications, the treatment plan will be based on number one thing. It will be based on scientific evidence. It is not that this Sunday I'm going to attend a course on ridge split, and on Monday every case is based on ridge split. It is not. You need to check the scientific evidence. If he is doing a particular technique, he might be very good at that. I might not be very good at that particular technique. Everybody knows advantages and their limitations. A successful prosthodontist knows his limitations, patient's needs and desire. Don't force the patient for implantology, because if you're forcing the patient to go for implants, then it's a problem. Then if the things go wrong, then you are in a fix what to do. Check for the local and systemic factors. Now, what are these local factors? The local factor means we all know that implants have more technical complications. Technical means the lab related. If you don't have access to good labs, it is better to stick to your conventional prosthodontics. If you have, either you need to change your labs or you need to send your cases to more good labs. You also need to see the patient's systemic factors, whether the patient can come again and again for technical problems. If yes, tell the patient, make him aware that these are the complications we can face, and I'll be there to handle this problem. Then let the patient decide. Now, after seeing those clinical cases and scientific studies, there's a few points I want to summarize. Supported restoration is only one of the ways of restoring a missing teeth. It is not the only method. Please note this thing. It is one of the method of restoring a teeth. It is not the only method. I told you there is no thing like as titanium deficiency. We'll not be doing good unnecessary placing implants. Implant supported single crowns are used when only one teeth is missing and the neighboring teeth are sound. You need to justify why you are inserting an implant, why you are doing advanced surgical procedures. For fixed denture prostheses that are solely implant supported or multiple implant supported crowns, the high frequency of technical complications can always lead to an increase in the treatment planning, and you should make the patient aware that they might have to come many times for this problem, this treatment. Whereas a tooth supported restorations have an increase of biological complication. Both these things, the patient should be made aware of this. The most important, after 10 years, the implant supported fixed denture process have a similar survival rate as conventional supported. Now, this is very important for a postgraduate student to know this thing, that it is similar. It is not that you are learning the advanced procedures, you are doing direct sinus lift, you are doing guided bone degenerations. It is absolutely fine you're doing it, but it should not be at the cost of knowing the basics of prosthodontics. The FPD, the cast partial dentures, the occlusion, they are the basic essence of a prosthodontist. If you don't know, because nobody will teach you FPD when you come out of your post-graduation. Nobody will teach you occlusion. People will share their experience. They will not be academically driven. You have the access to a lot of literature, lot of books on prosthodontics. The basics are like philosophies. The philosophies never change. The techniques might change. The technique which we are following might be an outdated technique after 10 years. The thing that will not change are the philosophy or the essence behind it. So basic conventional prosthodontics, the complete dentures, the RPDs, the FPDs, cast partial dentures, they are the essence of prosthodontics. So please, for those 3 years, do general or basic implant restorations, but concentrate more on your conventional FDPs. So in the end, I just want to say, wrong is wrong. No matter how many cases you are seeing on social media, if it is wrongly done, it is wrongly done. If everybody is doing it, but right is right. If even if nobody is doing it, so it means the core essence of prosthodontics is conventional prosthodontics. Implants is an option. It is not the whole sole criteria behind restorations. Thank you very much, everybody, for your patient hearing. Dr. Love. Over to you, Dr. Love.
Yeah. I think I will borrow only 1 minute and thank Dr. Satpreet to have thrown such a good light on this topic. And as very rightly pointed out, implant is yet another tool in the hands of a prosthodontist. It is not the be all and end all of our treatment. So thank you once again, Dr. Satpreet, for such a wonderful presentation.
Thank you, sir. Thank you, sir. It was an honor, sir. It was
Dr. Love
an
will
honor
take over from now.
Hello, can you hear me?
Yes, we can hear you.
Hello. Okay. Thank you so much, sir. Thank you, Dr. Satpreet, sir, for your enlightening lecture on prosthodontist or implantologist dilemma. You seriously provided some great facts and statistics regarding the program. Now, I would request Dr. Shitij Srivastava, sir, Head Department of Prosthodontics, to please give away the e-memento to our guest speaker. Over to you, Shitij, sir.
Thank you, Satpreet, for a beautiful lecture. Very apt and a lecture that I think all the PGs should be listening very carefully, because most of the times we are they are chasing to place an implant. So for them to understand that it is not that they shouldn't forget the basic philosophies of prosthodontics, and knowing all the aspects of prosthodontics is more important rather than pursuing just on concentrating on implants. Thank you so much, Satpreet. Looking forward to meeting you soon.
Soon, sir. Definitely, sir.
And we sometimes look forward, maybe this year, hope things settle down for the corona. Maybe you can come over here and give us a live lecture.
And anytime, sir, anytime. It will be an honor and a pleasure to be in Lucknow again, sir.
Thank you, Satpreet.
Thank you, sir. Now I would request Dr. Abhinav Shekhar, sir, to please say the vote of thanks to the speaker and to the audience.
Yeah, thank you, Dr. Love. Good afternoon, everyone. It's an honor to have been asked to offer a vote of thanks on the occasion of World Prosthodontic Day. On behalf of the entire team of Prosthodontics, I would like to thank our chairman, Shri Anurag Singh sir, secretary, Dr. Snehlata ma'am, MD Dr. Arohan, Advisor Shri Hanuman Singh Sir, CEO Shri CP Verma Sir for their support and providing us this platform. I would like to thank our respected principal sir who guided us and is the continuous source of inspiration for all of us. I am thankful to our CDE Director, Dr. Sudhir Kapoor Sir, and Director Prosthodontics, Dr. Ajay Singh Sir, for their immense suggestions. My deepest gratitude and sincere thanks to our Head of the Department, Dr. Shitij Srivastava Sir, for giving us this opportunity to thank everyone on this day and for being the backbone of this event. I want to extend my generous thanks to the guest speaker, who is a renowned identity from academics, our alumni, Dr. Satpreet Singh Bhasin. Thank you, sir, for your kind words and sharing your knowledge on this event on Prosthodontics Day. It has been a tribute to host all the participants of the webinar. I am thankful to all the participants for coming here and attending the online event. I am thankful, very thankful to Umesh ji and Pranjal Dental Lab for their contributions to make this event a success. I am sure that our department and institute will continue to organize many more events to spread the knowledge. A special thanks to Dr. Love Bhatia for organizing and managing the online event. I take this occurrence to thank the entire team of Prosthodontics for their support to make this event a great success. Thank you, everyone.
Thank you, all the delegates, for being a patient listener. It was an honor to host this event. Thank you to the head, to the principal, sir, to the management of Sardar Patel Postgraduate Institute. I would also like to extend my heartfelt thanks to Student Alumni Association, President, Vice President, Secretary of the association. Thank you. Thank you so much, everyone. Thank you for being online. Thank you.
Thanks, Satpreet.
Thank you, sir. Dr. Love, can I leave the meeting?
Yes, yes, Satpreet, you can, please.
Thank you, sir. Thank you.
Thank you, Satpreet. Thank you.